Good evening, everyone. Thank you so much for taking the time to join us for tonight's presentation on practical applications of 2.5% polyacrylamide hydrogel in Western performance horses. Tonight's presentation is brought to you by an expert group of panelists. Starting off tonight, we have Dr. Marty Tanner, who is a graduate of Mississippi State College of Veterinary Medicine and is the current owner of Tanner Equine in Weatherford, Texas. We also have Dr. Beau Whitaker, who is a graduate of Texas A&M College of Veterinary Medicine and is the current co-owner of Brazos Valley Equine Hospitals in Salado, Texas. We also have Dr. Vern Dryden, who is a graduate of Washington State College of Veterinary Medicine and is the current owner of Burr Oak Sports Medicine and Lameness, serving Kentucky, Florida, Arizona, and Texas, and is also the Chief Medical Officer at Wellness Ready. In addition to this outstanding group, we have Dr. J.D. Conway and Dr. Meg Green, who are professional services veterinarians here at Kentura Vet, who are going to help moderate and lead tonight's discussion. At the bottom of your screen, you will see that there is a Q&A box. At the end of tonight's discussion, we will have a Q&A portion, but please do not hold your questions until then. Please submit your questions in the box as they come to mind through tonight's discussion, and we will get to them at the end, as well as we will allow for people to unmute yourself if you prefer to ask a question that way. So without further ado, Dr. Conway, the floor is yours.
Thanks, Rachel, and thanks everyone out there who's joining tonight to talk about using Arthramid in the Western performance horse. We have an awesome panel, as Rachel mentioned. These guys are leaders among leaders within the Western performance arena, among other veterinarians scattered about this country, covering Florida, Kentucky, Texas, Arizona, across the U.S. for sure. With that being said, I just wanted to kind of start by talking with Dr. Tanner, Beau, and Dr. Vern Dryden about their experience with Arthramid a little bit and tell us a little bit about their practice. So on my screen and going left to right, it's Dr. Marty Tanner first. So maybe Marty, you can just enlighten us on the horses that you primarily see in your practice and experience with Arthramid.
Yeah, thanks for having me here. My practice focuses mainly on rodeo performance, roping, barrel racing, heavy into that, all of the rodeo performance events. And then the second biggest group would be thoroughbred racehorses. So that's kind of this, but more heavily on the Western performance. So that's the scope of the practice here. And I have been using Arthramid since it came out in, I think you said 2021.
Yes, sir.
And I've had really good results with it. So it's been key here in our practice.
Next would be Beau. What about you, Beau? What are horses? I know it's you're kind of in a unique area there.
Yeah, JD. We've got kind of a mix here. As far as Western performance, it's mostly rodeo horses, so barrel racing, roping horses. So work on a few cutters, a few reiners, but the majority are going to be more your rodeo disciplines. I do probably close to 50% English sport horse as well. So I do a lot of jumpers, a lot of dressage horses, along with rodeo horses as well.
Cool. And then what about Arthramid as far as in your practice, when you start using it and
yeah, same as Marty in 2021 when it first came out, been using it, had really good success with it. A lot of cases where the things just wouldn't work, including in tendon sheaths, which we're going to have a case of that today. Just found a lot of good applications for it.
Cool. And Vern, I know you're in Kentucky. What's going on up there? And tell us about the practice you got.
Yeah, thanks. So practice in Western performance horses is primarily reiners. Large portion of my practice is reiners, and I do have some hunter jumper and dressage clients. I've started using Arthramid similar when we were first to get it here in the States. So I've had great experiences with it. Started using it on advanced arthritic cases, but now using it quite often in younger horses, as you'll see from some of my case examples.
Yeah, it's awesome. I know you, so just to summarize, sounds like everybody's been using it for a long time and had a lot of success. And so I think we'll just dive into the cases that kind of represent some of those things. So we'll go through, there's about 7 cases to go through, and I look forward to hearing everybody's input as we go through them. But first will be Dr. Beau Whitaker's case. This first one, an 8-year-old quarter horse gelding used for barrel racing. Maybe just talk about what you saw in this horse, Beau, and how, why it came to see you.
Yeah, so the initial workup on this horse was done out in Idaho. The horse had a mild right hind lameness that blocked the medial femoral tibial joint. Initially, that horse was injected with HA and betamethasone. We go to the next slide.
Okay.
Okay. So the horse did end up having arthroscopy performed in November of 2023. They found a tear in the cranial medial meniscotibial ligament. Also, they had a grade 1 meniscal tear. There's also a cartilage defect noted. So it had, I guess three different things going on in that stifle, as well as a floating piece of cartilage in the right joint space that was removed. They did inject stem cells and HA in that horse post-op. So in January of 2024, when that horse was checked in March, it flexed off to the stifle flexion or the stifle extension. They injected the horse with high vis. So this is all prior to me seeing the horse. That summer, they went back to running the horse out in the rodeo circuit out west. In August, they felt the horse was lame. They injected the horse with Noltrex and high vis, as well as Shockwave with the stifle at that point. And the horse still wasn't right. So in October, it was injected with 1 ml of Arthramid, and this is still out in Idaho. I first examined the horse last November, so November 2024. The horse really wasn't that lame in a straight line, maybe a grade 1, but take the horse in a circle, it was a 3 out of 5, like a pretty pronounced right hind lameness in a circle to the right. We flexed the horse, it had a noticeable right hind lameness. On ultrasound, there's a pretty marked synovitis of the medial femoral tibial joint. There wasn't a ton of fluid on it, but it did have a pretty marked synovitis, as well as those hyperechogenic foci floating around in the fluid, which we often see. There's also a small osteophyte on the femur. So at that point,
what do you think? I'm sorry to, I just don't. I'm curious as your opinion on that hyperechogenic material and foci that I know all of us probably see that from time and again on the NFTs and when we're scanning those. Is that like, when you see that, what's your thought process? Along with
I think it's I've heard different theories. I've heard radiologists say that it's indication of some cartilage shedding. I don't know if that's the case or not. I mean, I do see it. Like the more of it I see, the more concerned I am. Usually, like some of those look like a thick snow globe when you ultrasound it, where there's just stuff everywhere. This case didn't have a ton of it, but obviously you can see it there in the ultrasound images. So to me, it's just an indicator of inflammation and damage in that joint.
Yeah.
So
you treated it with Arthramid in that style?
Yeah, with 3 mils, and the horse had just been injected a month prior with 1 mil. And I think that was one of the reasons I picked this case too, is just talking about dosing and how much you need to use. For me, it's kind of a dose-dependent effect relative to the pathology that you're dealing with, the amount of inflammation and synovitis in the joint. And so I do inject. I mean, I've injected stifles with 1 mil on horses that just, they're not lame. You might get a flexion response. Maybe you have a mild synovitis, and I think some of those cases 1 mil could be appropriate. In this case, I felt like with the history of the horse, there was quite a bit of pathology going on, and in this case, I thought 3 mils was a more appropriate dose. So this horse went to the Conquer Rehab Center. It was there from December to March of last year. The horse was undergoing aqua tread and also dry treadmill work. We tracked the lameness over time using the Slipe app. You can see there on the left, I think that was the first reading we did, where you've got a moderate asymmetry in that right hind limb. You can see the orange bar for those of you that aren't familiar with looking at the Slipe. You can also see on the like the blue waves, you can see where their horse is having less of a push off on that right hind. Then you can see over to the right, we can see the decrease in that asymmetry. You get used to looking at these, and I don't know. I don't try to get those horses where there's zero asymmetry. We're looking for a trend and improvement. And I like to get them in that gray bar, which is kind of they call it very mild usually if you analyze the wording on those slight apps. And so this horse had a pretty significant improvement from the time we first looked at it. I think that was like right after we injected it, to a couple months later or 2 months later, I think. So.
Do you use this quite a bit in rehab setting, or is this even more preliminary before you even get to the treatment rehab protocols?
Yeah, I use it a lot in rehab to track the horses. So when it's good to have a baseline when they first arrive, and then usually we'll try to track them. I don't know, every 2 weeks or so, 1 to 2 weeks, kind of depending on what the client wants to do, to track those horses as they go to make sure they're improving, and then make sure they're going back to work and they're good to go. So I find it really useful for that, and also nice too that you can send it. The clients can do it at home. And so they can download the app, and then the horse can go home, and then I can have them video the horse at home, and we can make sure once the horse is in work that it's still looking good. So,
cool.
All right. So in March, we had a mild increase in asymmetry. Like I said, we've been tracking on the slight. We just noticed that there was a little bit of increase. So went back and flexed the horse, had a mild flexion 2 out of 5 response. Probably overkill, but the client was like, just just do whatever we need to do. So we went ahead and put 3 mil more of Arthramid at that time in the stifle. The horse went back to competing, went back home. The horse is from Idaho area. And the horse has been doing great ever since, like doing really well. Won a lot of rodeos, done really good. I think they were going to come back. Last I heard, they were going to come back this fall and have the horse injected again with Arthramid. So
cool. That's an interesting case, and it kind of, to your point, and I've heard you mention this before, dosing Arthramid based on pathology of what's going on in the joint or whatever tissue you're putting in, synovial tissue. So I think it makes sense, and this is kind of one of those clearly defined situations. So next case is a 7-year-old quarter horse gelding, again used for barrel racing. So kind of a common theme that barrel horses kind of get some pathology.
Yeah. And this isn't going to be a case for, we're trying to get the horse back into work. We're just trying to basically save the horse's life on this case. So we got just a severe overreach injury. And again, I wasn't the initial veterinarian that had worked on the horse, but it just obliterated the SDFT and DDFT. I've never seen an overreach injury this bad in a horse before. It had previously been treated with PRP, several rounds of PRP, multiple rounds of shockwave therapy. And when I initially saw the horse, he was a 4+ out of 5 on that leg, basically hopping on 3 legs. So this image was taken, I think, probably maybe 6 to 8 months after the initial injury happened. There's not a whole lot of definition there between the SDFT and DDFT. A lot of just diffuse damage. This is just one image, but you go up and down that palmar fetlock, and the whole thing, just some areas probably look worse than that. This is, I was starting to, at this point, I had injected Arthramid in multiple tendon sheaths, but nothing to this severity of pathology. I've been using it a lot. Manica flexuria tears with really good luck. A lot of chronic tendon sheath issues that I had really good luck with, getting those horses back into work. In this case, the owner just loved the horse and wanted to save its life. And so I injected 2 mils of Arthramid into the digital flexor sheath. About 3 weeks post-injection, the horse was walking sound on the leg.
Wow.
About 6 months post-injection, the horse will start to get lame again. And so we'll just repeat the 2 mil injection. The horse goes back to being sound. That was 3 years ago. First time I injected the horse with that tendon sheath. And the horse maintains pretty good, if it gets Arthramid about every 6 months.
That's amazing.
Yeah. It was a pretty interesting case.
I mean, and you said it was an overreach, so it's just, that's I think all horse types can see that injury, but especially it seems like the timed event horses, but I'm sure even and Vern can attest to it on the reining side as well.
Yeah, and this horse just lives in a pasture now. It didn't go back to barrel racing, and we knew the horse wouldn't, and the owner wasn't expecting that. But at the time, they were going to have to euthanize the horse prior to doing this. So
that's great. Any thoughts there, Marty or Vern, on these cases, or you got any thoughts on? We've talked about dosing and Beau mentioned it. Any?
Yeah, I've definitely seen a response to the volume that you place. If I get a good response with 1 mil, but it's not all the benefit that I think that it should be getting, I'll come back and add another, no problem, in a week or two, come back and add another syringe and top it off. So I have no problem coming back, especially if I get a good response, but it's not quite as good as I need it to be. I got no problem coming back and putting another vial in.
Yeah. How long are you waiting, Vern, before you make that judgment?
Probably about 2 to 3 weeks, give it enough time to have that synovium calm down and get a chance to reevaluate the horse. So yeah, about 2 to 3 weeks.
Okay.
I've used it the same way as Vern. I'll come back and look at those horses anywhere from 3 to sometimes 30 days and add, re-up the dose if we're not getting the response we get.
Yeah.
So I think it is. I think everybody's point's good. Beau made a good point, is it can be dose dependent. Not only the severity of the injury, but the size of the joint you're dealing with. I've stuck that stuff everywhere you can stick it. And it's, so bigger the joint, more you need.
Makes sense to me for sure. And the horses that I've seen, at least up here in Cody, over the last 2 years that I've been using Arthramid, it's very similar analysis and treatment regimen. So kind of just moving through cases, and we'll get to a lot more of your questions again at the end. But Dr. Dryden's got some really cool reining horse cases and brings up some other points of using Arthramid that we haven't talked about yet. So I'm excited to get to those. But this first horse is a 3-year-old quarter horse stallion reining horse. Obviously, that's an important time frame, important years in the reining horse, cow horse, aged horses.
Yeah, absolutely. The aged horse events are big time, and the futurities are for the reiners that's kind of our bit of our Super Bowl. This happened. This was about, I don't know, several years ago. I saw this horse for the first time. Really nice, well-bred 3-year-old quarter horse stallion. The horse was in training at a high-level professionals facility. They weren't sure, if the horse was going to be able to even make it to the futurity. It came up about 2 out of 5 lame on the left front. Palpation and soft tissues were all within normal limits, negative to hoof testers. Mild to moderate fusion on the left front fetlock. Got a 2+ positive on left front distal inflection. When I isolated the fetlock, definitely got a strong positive flexion. Started out with the PD block, made no change. Then did abaxial, about 30% improved. Low 4-point, got it all the way sound. And then we went ahead and took some radiograms. So you kind of have to look a little bit close, but you can see some pretty significant osteophyte on the lateral aspect of that proximal P1. There is some cartilage damage and erosion on the surface of that joint. I did have a radiologist look at these images just because of the nature of what we were dealing with, and confirmed that there was definitely some cartilage damage and structural damage to that joint space and narrowing of that joint space. So we went ahead and treated this with Beacon Advance. Went ahead and treated this with just betamethasone and HA because the client wasn't real excited about using Arthramid yet. So this is what we chose. The horse went sound a week later and resumed training. And that soundness lasted about a month and came lame again. This time it was about a 1 out of 5 on the left front. This time I went ahead and just went right to the left, to the fetlock joint and blocked it out. The horse went sound. So we knew that we definitely had a problem there, based off of the radiographs and the radiology report and how he had responded previously. So at this point, I convinced them to give Arthramid a try. We put Arthramid, 1 vial of Arthramid in there, in the left front fetlock. The horse had 10 days of just walking, and then when he trotted sound, I told them they could start back to training. So they started the horse back into training at that point. And so move forward to November 5th, right before the futurity season is in full swing. The horse started to show just a little bit of lameness on that left front again. And this is where I think the dosing and timing makes a big difference. I think hindsight, I probably would have just went ahead and put 2 vials of Arthramid into that fetlock right off the bat. But knowing what I know now, hindsight's 2020. So the horse at that point was a 1 out of 5 on the left circle, and then about a 1 out of 5 on the fetlock flexion. At this point, I did go ahead and treat with 2 mils of Arthramid. The horse resumed soundness, made the NRHA futurity finals, level 4 finals. Since then, it's been in all major events, and he's won about $350,000. So that's a pretty good testament to how well this works for a horse that we weren't even sure that we would get through the futurity, to go on and do that. And he's maintained on about a 6 to 8 month schedule with 2 mils of Arthramid.
Interesting. If I back up to like when you were initially going through the diagnostics and you started with the PD and you went to the abaxial and it was like 30% better, then you moved to a low 4 and you got him there. How often, and maybe this is for the group, would you jump from an abaxial to, and you said you had some positive to fetlock flexion. How often would you jump to just blocking the fetlock joint instead of doing a low 4? Or would you always just go to a low 4? Because I noticed, I know later you went to the fetlock, but after you'd taken x-rays, I guess I just wonder if sometimes we shouldn't do that. I mean, I don't know. Any thoughts there, Vern, or the group?
I totally agree with you. I think hindsight, I probably should have just blocked the joint. I think I was thinking I'm probably going to inject the joint anyways. I don't want to go in this joint twice because we were at a small horse show, and the least amount of times you can enter a joint at
Sure.
a situation like that, the better off you are. So I think it was a little bit of circumstances that I decided not to, but I think in a clinical setting, yeah, absolutely, I would have tapped that joint and blocked it.
Yeah, I almost always block the fetlock before I do low 4 point. I mean, there might be situations like Vern said, but if I'm in the clinic, I'm for sure most of the time going to do that, especially if they flex off. I'm going to do that. Sometimes I'll do it before I do an abaxial, because I think sometimes your abaxial blocks can what are you really blocking? And so if I'm suspicious of fetlock, I'll block the fetlock prior to doing an abaxial nerve block, because I'm just afraid it's going to confuse my blocking going the other way around. So.
Yeah, I agree. I mean, we have just going to be case dependent. I know some of those we all do low 4 points. We all do fetlock blocks at the same time, but I can understand why you wouldn't want to block that joint at a show. But in a clinical setting, yeah, I agree. And I also agree with your comment, Beau, about abaxials. I have 2 cases. They didn't have anything to do with Arthramid, but they're pretty interesting because I sent them for an MRI that I blocked to a PD. They were great. Both of these were grade 3 solid lamenesses, and I did a PD block. They'd go 100% sound. I could not find anything and sent it for an MRI, and both of those horses had fetlock issues on an MRI. So I think nerve blocks, they're a very useful tool. Man, sometimes you can't live and die by them. They'll fool you sometimes. Yeah.
Yeah, I think that's a lesson for me for sure, and probably those folks that are out there. It's that's super interesting, and I'm glad to gain some knowledge from you guys on that for sure. And um, it's also cool that this horse, being a 3-year-old youngster, got, Arthramid and is now competing at a high level, obviously, and getting Arthramid quite a bit over this time frame. And so, now I'm sure as we're coming into the next part of his career, continues on, but really interesting. The second case that you
Well,
have, Vern, go ahead. Sorry.
I was going to say that case in particular made a believer out of a lot of people in Arthramid. So I think that was a large reason why, I think it's been pretty well accepted in the reining community because of that.
This next one is a 7-year-old quarter horse mare, Rainer again. And this is the one that I was kind of excited about too, just because it's a little different and it speaks to other things. So might maybe just go into this one discussion.
Absolutely. So this is actually a fun case for me because I knew this mare when she was 3 years old. I got to do a pre-purchase on her after she did extremely well at the Congress Quarter Horse Show in Columbus, Ohio, and the reining. She won, I think, a level 2 open futurity as a 3-year-old there, and I got to pre-purchase her right after she won that class. And I've been following her along through her career. Really, really great mare. So the owners of this mare, dear friends of mine, I come and work on their horses for them. And this little mare, she's had some fetlock issues up front. She was due for routine lameness, and I haven't seen this mare in a while, probably about 6 to 8 months. And she definitely packed on some pounds. So she was probably a body condition score of 6 or 7 at least, with the mild crusty neck on lameness exam. She was lame on both fronts, one on each, one on the right front on right circle, one on the left front on left circle, flex positive on both front fetlocks and positive on both hocks. So I knew I was going to need to treat this mare, both fetlocks and hocks. So I decided that, given her little bit of weight gain and her age as a 7-year-old, we would here's our radiographs just to show she's definitely got some arthritic changes in those fetlocks. The right fetlock looks about the same, but pretty good osteophyte there on both the left front and the right front, but the right front's not up, but just to show you what she looks like. But before I injected this mare, I wanted to make sure that our insulin levels were within normal range or within a good range, because it's so risky to treat these horses that have elevated insulin with a corticosteroid for risk of inducing a laminitis episode. So we pulled blood, ran a simple stall side blood test with the Wellness Ready system, gave us an answer in 15 minutes. Her insulin was elevated. It was 48 microunits per milliliter, microunits of insulin per milliliter. So at that moment, I said, hey, we're not going to treat this mare with any corticosteroids and risk having a laminitis episode. Given the recent studies that have been done looking at insulin ranges and spikes to insulin post-injection with corticosteroids that can get up into 300 to 400 range, we opted to avoid corticosteroids, and Arthramid was a great fit. We had used Arthramid in the past and had really good luck. So due to her elevated insulin levels, we treated both front fetlocks and hocks with Arthramid. And the mare went and showed 2 weeks later and has been doing fantastic.
And how often, I guess in these mares or geldings or whatever, are you doing the Wellness Ready to kind of check those insulin levels just on every case, or just cases you see that crusty neck and have a suspicion that, maybe there's some insulin dysregulation, or what's your thought process?
Yeah, absolutely. Great question. I check any horses that I am phenotypically suspect of. So if they're overweight, they got a crusty neck, I'm definitely, if they look like they're even an ounce of metabolic issue going on, I'm going to check their check their insulin levels before I use a corticosteroid. I'm also checking horses that are older that may not look like they are metabolic, but those older cushingoid horses that are skinny horses, but still may have a hyperinsulinemia due to the Cushing's. So that's a really big one that I think we need to pay attention to, or horses that don't necessarily fit the bill of a fat overweight horse, but of the PPID horses that are the skinny horses that may also have an underlying hyperinsulinemia. And then horses that are in a stressful event. I can't tell you how many horses I've checked insulin on before I've injected it at shows where they've traveled for 18 hours. They've gone through the first round of competition, and they're stressed out. We may need to, treat something on them. Well, I'm gonna check their insulin levels, because that stress level can definitely induce hyperinsulinemic state, and you don't want to get in trouble treating a horse on the showgrounds, and then have it wind up, laminitic. So I think that's a important way to look at it too.
Perfect. Any thoughts there, Marty or Beau, with you guys using the Wellness Ready, or is Arthramid your go-to, I guess, in those cases where you suspect a horse that's has insulin dysregulation, metabolic?
Yes, if I suspect that, I go straight to Arthramid. No corticosteroids in those horses at all. It's just not worth the risk. Yeah. I also have a question for the panel too. This sprung into my mind. What are you telling your clients? Okay, we're going to dose Arthramid today. When do you expect to see results? And I know that's a little bit case dependent, and you're max out. So you're maxed out at about 2 weeks, right? Everybody agree with that? You're going to get what you're going to get at that point. But in your eyes of the population of horses you treat, how soon are you seeing improvement?
I'm seeing a lot sooner than 2 weeks. I'll tell you that. I usually see within 5 to 7 days is kind of my experience, is where I see it.
Yeah, I've seen them in a week. I tell the clients 2 weeks, but I've certainly seen it sooner than that.
Yeah, and I've seen it sooner than that. I just was wondering, talking to your clients, like, what are you telling them to look for? Because as we all know, especially in the rodeo world, you look at this horse and like, well, we need to inject this and this, and they're like, well, okay, I'm entered tomorrow night at the rodeo. So
yeah,
anyway, I was just curious. Sometimes I like to check myself against what everybody else is saying as well.
No, I feel the same, and a lot of the same as you guys. I do think we have some cool information coming out from CSU. We did a study there through the carpal chip model, running Arthramid, and what's interesting is when Arthramid was placed into the joint 2 weeks after they chipped those horses, and seeing sort of the down regulation of certain things, the downstream effects, and the upregulation of the anti-inflammatory, and the things that we get as a benefit of improving the structure of the synovial membrane, improving the elasticity of the synovial membrane and everything. And I think that happens a lot sooner than we think. So I think you're right on, Marty and Beau and Vern. So it really cool to see that. Next case again, Vern, this is yours, 5-year-old quarter horse gelding reiner, from this past February.
Yeah, so this was a new case to me. Had never seen this horse. Presented in February. Horse was definitely very lame, left hind, strong positive to sorry, I think there might be something on your screen, JD.
Oh,
got an update coming
on my screen. Oh, sorry.
Yeah.
There you go. My bad. There you go.
No worries.
I've got 3 screens open, so it's I'm trying to check them all.
I was thinking I was going to have to update this thing to keep going, but I'm glad I don't. All right, so strong positive on left hock flexion. The horse had history of the hocks being injected with Depo and HA about 60 days prior. So we went ahead and shot some films to see what we were working with. And pretty advanced OA and that DIT. So if you all can appreciate that, pretty significant changes there. Definitely some medial collapse, working on fusing that DIT joint. So I said, well, the best thing I can offer is to go ahead and treat with Arthramid. And in some of these cases, I only use a half mil of Arthramid, especially in these quarter horses that have collapsed joints. You're not going to fit much more than a half mil in there. And with a little bit of betamethasone, just because I wanted to make sure that we got this horse comfortable. So treated that horse. The horse became sound 2 weeks later, went back into full training. The horse has won several major NHA events this year. I literally just saw this horse and treated him a week and a half ago. Again, so yeah, so he's on about a every 6 month schedule. I think is going to be what he's going to require to maintain this. Now, a part of me wonders what it's going to do to have the Arthramid present with the fusing process. Are we going to reduce the fusing process, the ankylosis of that joint space, or are we, is it going to continue to progress? It's been interesting, and I'll be excited to see how this horse progresses. Question for the panel: do you guys have any experience with fusing hock joints and progression being treated with Arthramid?
I don't have a case specifically with Arthramid, but I think experience, as we've all know, that if that joint's comfortable and they use that joint more, the more they use it, the quicker it's going to fuse. So I think it would be interesting to see how it turns out, but I bet it doesn't have any detrimental effects, would be because it's going to be incorporated into the joint capsule relatively quick. So I would think.
Yeah, I would agree. I wouldn't think it would change the progression of the fusing significantly. I mean, I don't have any cases that were fusing and then I could follow it like that. I certainly use it in hocks, but I don't think I've had a fusing hock where I could say I'd injected it and followed it and could ascertain whether I thought it was changing the fusing process or not.
Yeah, I don't.
Yeah, just curious.
Yeah, I don't have. I like you guys. I've used it in quite a few hawks now, and but it seems like what's interesting to me, and I guess when I first came on to Contura, just thought, well, maybe this is not a good place to use it, and I was totally wrong. And I've had some of the best success treating hawks with Arthramid, and it was interesting, and this could kind of get to maybe the next case, but that some of these low motion joints do respond, and I think that synovitis is a big issue in these low motion joints that aren't radiocarpal or whatever, stifle or something. I mean, obviously there's a lot going on there with the synovial membrane, but I think we tend to forget that some of maybe these low motion, that a lot of it is related to that synovium itself.
Yeah. I've used it in some fusing pastures, kind of similar pathology where it was really effective. But yeah.
And I find myself injecting young horses' hocks with Arthramid a lot more, and I find that I have a really long lasting effect with them. I can treat them, middle of the year, and I don't have to touch them, for the rest of the year. I think it's been really helpful in my hands to treat them once a year and then to go back in those hocks.
Yeah. This kind of gets to Beau's discussion on pasterns. This another reigning quarter horse for Vern.
Yeah, so this is a really interesting case again. A case I've known for a while. He's had lameness issues up front for a while, but we've been able to manage through it. He came to me at a horse show in May. He was 3 out of 5 on the left front. We blocked to a PD, blocked 100%, and then switched over to the right front at a 2 out of 5. So went ahead and shot some films. He's got some moderate OA in the left coffin. You can see there, and then also some pretty advanced OA in the right front pastern. So We had known that he had pastern issues. I'd treated his pastern once or twice before, but the coffin joint in the front was definitely not known to us. So we went ahead and treated his coffin on the left front and his pastern on the right front with 1 ml of Arthramid and 6 mg of beta on each one. We also added some shoeing changes to reduce toe length and put an omnidirectional breakover shoe with pads to help with some concussion. The horse has been doing well since, and just won a class for this little guy last week.
That's really cool. On the combination of using Arthramid with Beta Vet or betamethasone, I know Beau, you did some work on it. From a safety standpoint, maybe this is a good time to just talk about that and what you saw, at least in the combination therapy, because I know we've all probably used it combined, but at least from the research side.
Yeah, I did a study that got published in JAVMA a few months ago, or this spring, where we were just doing a combination of Arthramid and betamethasone in fetlock joints in a group of horses. Basically, it was basically a safety study, just because Arthramid or Contura wanted to be able to, put that on the label, be able to use that on the label, because prior to that it said don't combine it, just because there wasn't any data on it. So yeah, it was great. The horses did well. We kind of expected it just because anecdotally and clinically everybody was seeing good results with the combination. So the study was good. It was safe. But there's been some studies done out of Europe, like with really large numbers of horses, a couple hundred horses, using Arthramid, where they had concurrent use, and it was a pretty good number, 76 of them or something like that. There was concurrent use, which is either methylpred or Kenalog, I think, in those horses out of Europe. And their impression was that it was safe, that those horses responded just as well as the Arthramid horses alone. There is some, it's kind of some, I don't know, I wouldn't call it controversy, but concern that the combination could have some negative effects on the integration of the Arthramid potentially, or at least on the long-term effectiveness, because corticosteroids decreased fibroblast migration. And that may be part of what's going on, when that integrates. But clinically, with some pretty large numbers, it seems it doesn't really affect the long-term efficacy of the Arthramid. I know we often use it so we get that quick clinic, the quicker clinical response, and also that quick decrease in inflammation. And on the back end, you kind of get that longer-term effect of the Arthramid integration. But yeah, it does appear safe, and based on at least clinical responses, it doesn't appear to affect the efficacy of the Arthramid when you combine them.
Yep. Marty, do you combine them much, or?
I do. I combine them, and in the case that I brought, that's a little bit involved in that case as well, but I do combine them. And sometimes I will, and I'll step off into my case a little bit. I will, I call it like preparing the joint. If they've got a significant amount of inflammation, I might put some corticosteroid and some HA, and then wait just a little bit of time, and then bring that horse back in, and then put the Arthramid in. I think I've had really good success with that method.
Well, we can talk about that here, really, if you want. Just this 6-year-old quarter horse mare. I know this is near and dear to some of the people here at Contura, especially Laura. And her son there riding that horse.
This is her son's horse, but this was a 6-year-old mare. I think I don't want to tell it wrong. I think I was vet number 3 on this thing, but I chose this case because there's some interesting points to make that have nothing to do with Arthramid. But presented with a right hind lameness, non-responsive steroid and HA therapy in the past, the medial femoral tibial joint. When I looked at this mare at the hospital, she was a grade 3 right hind, and which when you did a flexion, I mean, she wasn't a grade 4, but she would increase from that grade 3 with flexion of the right hind, and it didn't matter which direction you jogged her. I did intra-articular blocks of medial femoral tibial joint, and it improved the lameness, but it didn't resolve it. And I come back and blocked the lateral femoral tibial joint, and it completely resolved the lameness. And it only had when I say partially resolved, it was less than 50% with the medial. But the lateral did clean up the lameness. So I took some x-rays, and there was and this is hard to interpret, and I'm not sure I'm the best at interpreting it, but it was suggestive that you had a little intercondylar change and impingement in that stifle. On ultrasound, I didn't see anything of significant findings. We talked about scoping the joint, and then we elected just to try to treat the joint. So here are the x-rays. It doesn't show up very good in here as much as it does in real life, but I think one thing that I've learned to look at with scoping some of these stifles is that intercondylar area is pretty important. And if you look where your intercondylar eminence is and the axial margin of the medial condyle, you'll see that it almost looks like there's a little bit of lipping or spurring on the edge of that medial condyle. I think that's significant because the contralateral stifle did not have that. And I see, especially with some students coming through, that they're not really taught to look at that area of the stifle, but I think it's pretty important personally, at least in the population of horses that I look at. So not everybody will agree that there's some change there. I personally thought there was some, although it's can't prove that to you because we didn't scope it. So I put betamethasone and hyaluronic acid in this mare, and I did a follow-up in 2 weeks. And she had reduced from a grade 3 to a 1.5 in the right hind. So I repeated my blocks, and I do this sometimes, and it was because this is one of the points. I think we always need to be our worst critic. And I noticed Dr. Dryden, when he did the fetlock, he did the low 4-point, and he'd come back and confirm the horse was not right. Don't be scared to repeat blocks, because when I did the block again, I got the same result. So I felt comfortable then that we were, I hadn't missed something, because as we all had in this panel, you'll have a horse that comes in, he's lame, and you'll treat what you think is the sole source of the lameness only to find out it was multidimensional, and you got one cleared up, but you don't have a sound horse yet because there's a second problem. But anyway, so we talked about arthroscopy, and we elected to just do regenerative therapy. We did that for 60 days with Renovo. And then we came back on top of that and followed it up with Arthramid. And I used 4 vials in this mare. Checked the mare at 60-day intervals. She went sound. Of course, she was sound before we started back. I used the rest in the regenerative therapy, and the mare did sound up. We put Arthramid in there in the mare, rechecked her at 60-day intervals. She stayed sound for 6 months. And she only became slightly off at that point in that right stifle. 7 months, Arthramid was re-injected, and it was 12 months before we had to re-inject it again. And then on follow-up exams, we just did follow-up exams routinely on her till we started seeing lameness, and we treated it again. But I like to try to find so if you look at this history, you think, well, about if you want to stay ahead of this mare, probably about that 7-month period, you need to be re-injecting her. But we maintain this mare with Arthramid exclusively in that stifle, and I think they got a video they can show
Some people think I'm wrong.
what she looks like now, I think. He wanted to show it bridleless, by the way.
But I want what I want when I want. Yeah. I'm going on till I'm gone. Yeah. Can you feel it? Can you feel it?
So prior to this mare couldn't even be used. So this was a very successful case, but I chose it because we can't forget, at least in the Western Performance horse, there's a lateral joint to that stifle too, and then don't be scared to reblock one. So that's my one case. Showed me up with more cases.
Oh no, I love it. I mean, it's when I talked to you earlier about this is not forgetting about the lateral pouch. I mean, we always look at the pathology in the medial side of the joint and the stifle. I mean, how I'm guilty of just not overlooking that, but just thinking it's always medial. But it's a good case to show it's not. How often do you inject both medial and lateral on these stifle horses, Marty? You just almost every
Personally,
yeah,
it's routinely
yeah,
because I've just been burned too many times. And you know, it was fortunate I got to see Dr. Lewis and Dr. Hayes scope so many of those things at Elgin. You don't, I mean, there's a lot of pathology there, but most of the injuries that we see in these Western, especially in these rodeo horses, like head horses and barrel horses, you know, they're torque injuries to this. We're talking about the stifle, and you know, they're
right.
torque injuries or turn injuries to that stifle. And how are you going to torque the medial joint without torquing the lateral joint? I mean, that thing works as a, we all know it works as a unit. So it's fairly routine in my practice to do lateral and medial pouches.
Yeah. What about you guys?
I wouldn't say it's routine. Like if they block to it or I ultrasound, see pathology or fusion, I'll inject it. But it's not a practice to just do both on most cases. I will based on imaging or blocking.
Yeah, definitely. If I get one that flexes strong or they're quite lame and I isolate it to the stifle, I'm going to be imaging that lateral compartment and making sure that I know what I've got. And yeah, I'm definitely not. It's not a extremely routine for me to inject the lateral compartment, but it's not often, if that makes sense.
Yeah. One thing I remember kind of going through with Dr. Frisbee back in the vet school days was, blocking the stifle with using the one needle entry point and going across and things. And I actually don't do it that way because in this case, you kind of learn if you maybe block the medial, it didn't get completely sound, you go to the lateral and then you get completely sound. And maybe there's something to kind of taking it a step-by-step approach. I don't know if you guys do that or if you just block every joint, all three when you're blocking these stifles.
I
I
usually
usually start with the medial and then go to the lateral if I need to. I don't
Yeah.
block femoral patellar a lot unless there's radiographic evidence or a fusion. Or if I'm not getting it from the other ones, but I still think it's the stifle. So
same.
Yep. Cool. So those are the cases that we kind of wrapped up and the 7, very different covering, stifles, hocks, pasterns, fetlocks, all of the above. I know that there's probably some questions amongst the audience. It's been about an hour, so maybe we should jump into a few of those and see where that takes us at this point. If Meg or Rachel have got some of those questions.
I can help with that. We have several questions actually. I'll just start from the top, if that's okay. And one of the questions is from Dr. Coker. I thought Arthramid was a one-time injection for a specific joint. I think we've kind of covered off on that information, but any feedback as far as sort of what your thoughts are and where you've gone from the panelists on that thought and maybe how your thoughts have changed as far as using it once and then coming back and repeated injections over time.
oh yeah, I don't. I think probably all of us use it.
I think we all do.
Cases.
Yeah.
Yeah, it was used multiple times. I think in most of the cases that were presented. So I certainly have no qualms about doing that.
And I haven't, it doesn't, I don't think I put it in the TMJ yet, but I put it everywhere else you can put it.
Yeah, I have it.
It works good versus too, by the way. Just don't forget the navicular bursts. At least I have had luck with it in a navicular
Yeah.
burst.
Dr. Conley actually brought that question up. Does anybody use Arthramid and navicular bursts for non-responsive navicular disease?
Yeah, I've gone to using half a mil though. I've just had some that got pretty sore after a full syringe, but I haven't had a problem with a half mil, and I still get the results. But I think it's just the volume and the burst is so small. In some cases, I think that it gets painful. I mean, a lot of things you inject bursts and the sources get painful afterwards. A lot of those cases,
Yeah.
they basically once your abaxial block wears off, some of those horses are pretty sore no matter what you inject. But haven't had a problem doing half a mil.
Do you guys ever routinely would mix like in a case of a bursa, and this comes from overseas when I was in Denmark with meeting with a bunch of European vets that they'll mix carbocaine in some of their Arthramid injections, especially on a bursa, like a 0.5 ml carbocaine or a little bit of carbocaine with it. Have you ever thought about
I've
that?
never have.
Okay.
I haven't. Were they doing that just to prevent them from post-injection soreness?
Yeah, I think so. It kind of gets to what Beau was saying, maybe it's more of a volume, but I think it's to just tamp down the potential windup. And that was it was something that Dr. Mark Cooner had talked about, and he's got quite a few horses in a sport horse study where he talks about it. So in coffins and bursas, but um, I've utilized it in some other joints, not in bursas in that fashion. So.
So there's a couple questions. I'm going to combine a couple people's questions just because I think it's good to talk about different joints. And one of them comes from Dr. Thompson, and she asks, as I notice a lack of representation for coffin joint injections. Are you finding that they may be underrepresented in the Western Performance Horse, or are you using it less frequently in coffin joints in general?
I would say
I've used it.
underrepresented. We definitely use it a lot in coffin joints for sure. At least
I
in
think
my
it just happened to fall on case selection. We were trying to find
Yeah.
something we thought would be interesting, but I use it. That may be one of the more common places I use it, actually.
Yeah. Yeah.
Another question that's come up is, have you used it in neck injections, and what are your thoughts on the results? Is this something that you like to do, or is there something better?
I've used it in mini necks, and I love it. Some of those non-responsive facets, I find that if I've definitely got arthritic changes there, it works very well for me.
One question with regards to that, Vern, I know you and I've talked about it with these neck cases. Do you do it bilaterally on those horses on either side, or have you used it unilaterally? I know we've kind of had different cases that we've talked about for those necks, so I thought that might be a good talking point as well.
Yeah, so one case in particular, I did unilaterally one site on the site that we knew was the problem, and it had become unresponsive. So we just put one dose of Arthramid into that facet, and the horse responded amazing. So yeah, I don't have a problem doing it unilaterally. Most of the time, if I'm going to treat one side, I'm going to treat the other. But in that instance, it was more acceptable to just do the one side.
Okay. The next question is actually coming from Dr. Phil Hammock, and this is actually looking at talking about reevaluating the ultrasounds and things like that after you've done your injections and coming back. Have you considered re-ultrasounding the stifle? I like to reuse ultrasound 3 to 4 weeks to confirm the synovitis has resolved, and then treat again if needed. What are your thoughts on rechecking, especially when you're doing these cases where you're thinking about going back in and re-injecting? Is that something that you commonly do in your practices?
I'm not usually re-ultrasounding. I'm going more on their clinical appearance at that point. Generally, I'm not using ultrasound to decide if I'm going to inject more. Now, if they're not better, I might go back and reevaluate it.
I think if they come in for a recheck, kind of what Beau said, depends on what the horse looks like, but if we have any questions, then I'll re-ultrasound. If they're coming in for a recheck, I would say probably more than not, I will just scan it just to see what I'm learning, how well it responded. But if he's not sound, I didn't respond too well.
Sure. I think that's one thing that we have learned over the past 3 years since I've been with this organization. I think being able to see, utilizing the soft tissue and ultrasounding these horses and rechecking. I know this is something that I have talked with veterinarians across the country, and that is something that they are finding. Dr. Cooper Williams has done quite a bit of that in his practice and shared that with me, that he does see the synovitis and looking at being able to measure the synovitis in these cases, and finds especially that horses that have been treated with Arthramid, that he does over time see those changes in those horses. And so when he is coming back to do those rechecks, that's something that he routinely does. So I do think it's something to consider in your practices as you're rechecking these horses, and maybe considering re-injecting as well. So just a tidbit from him and what we've learned from his practice. Another question that Dr. Hammock said, in regards to, just curious regarding maintaining these joints every 6 months. If a lameness is reoccurring, which is what reconstitutes retreating, is underlying pathology progressing? Is the 6 months a satisfactory objective for determining success of the treatment?
So that's a great question. And I think that's where re-imaging, evaluating the treatment protocol and making sure that you're maintaining highest standards is very important. So I think like when Dr. Tanner said, horse comes in and they're not responding, then we're going back to the drawing board and we're going to, reevaluate, maybe do some advanced imaging and see what else we can do, or if another treatment option is indicated. So that's a very good point.
That is a good point, and I think you're also going to have to weigh it in with the pathology that you started out with. And I know that sounds silly to say, but some of these joints that are, especially in these high motion joints, if they've got a lot of OA in there, you're going to inject them more frequently than you do the young horse that's not. So
Yeah,
it's going to vary. In my opinion, it's going to swing back and forth, but
I can tell you, at least from the chip model of looking at horses, and that's on a more defined timeline of 70 days, that when they injected those horses, they got better. All of them were better in 49 days. So basically 30 days after they were injected, they were better. But because they're at performance and we're continuing to treadmill them and work them hard, leaving those chips in the joint, they started to fade off. We started to, and so I think it speaks to having to go back in there when you've got, some pathology, just like a barrel horse is out there running, you've injected it. They're continuing to beat it up going down the road or whatever it is, that you may have to go in that same spot again and put some more gel in there. The synovial membrane might be disrupted in another location, or it just needs more, to Beau's point earlier. So
yeah, it can be work dependent as you're talking. In certain times of the year, especially these PRCA horses, they're hitting them hard this time of year, and so you're going to have to go in there more frequently. That's one of the advantages of Arthramid, is at least I haven't heard, unless you're just using some crazy interval, that's not a drawback of this product. You can go back in.
no, we have a safety study on racehorses from Australia, and Stuart Valance's practice coming out, showing they looked at 703 horses, and a couple of those horses got injected 14 times with Arthramid at 2 ml doses. I mean, they had massive amounts in it, and they still performed. They had no catastrophic injury at all. They maintained their placing or rating within races. So I think it's, to your point, Marty, I think it's one of the safer things.
So this question's for you from Dr. Bass. He was curious, talking about the digital tendon sheath. He said, what do you think the Arthramid did to help the soundness in the digital tendon sheath? I understand the mode of action and synovitis model, but curious on your thoughts on the mode of action for soft tissue injury.
Yeah, I did a tendon sheath study here last year on a horse, because I'd seen so many positive results treating tendon sheaths. I talked to Contura, and so we did a terminal study on a horse where we went in surgically and created lesions of the DDFT and the manica in this horse in 2 legs, and came back and injected Arthramid in one of those tendon sheaths, 2 mils, and then did histopath and compared histopath on the tendon sheaths, the DDFT and the manica. And so some of that we were wondering too, like, if you have like some tendon fraying, does Arthramid actually have any integration with the tendon, like in some of those cases? And it did not, but it did have an affinity for the damaged synovium. And so we found that the Arthramid was integrating in the damaged synovium adjacent to where we created those lesions, and it wasn't integrating in the healthy synovium. And so it seemed to have a preference for the damaged portion of the synovium. Now, I mean, some of that Arthramid probably ended up just because of gravity and fluid dynamics in the distal recess of the sheath, I'm guessing. But the portion that remained in that proximal part of the sheath was integrated with the damaged synovium. And so I think in those cases, when you've got, inflammation, we're basically, decreasing the inflammatory mediators that are getting released from the synovium into the sheath and keeping those macrophages busy with the Arthramid instead of spitting out, IL-1, all that stuff into the tendon sheath. And so I think that's a big part of what it's doing. And that was the most interesting part of that study was the preferential integration with the damaged part of the synovium.
One question in regard to the tendon sheath that came from Dr. Thompson. In the sheath, what is the maximum amount that you would put into it? I know in that study we did 2 mLs. Is there a larger volume or a smaller volume that you've done in the past?
I've done 1 or 2 in all of them. I don't think I've done more than 2 in one at this point. I've had a really good response with 2. Most of the cases I've used 2. I've had some I've used 1. I'm sure you could. It's a large volume structure, pretty much as far as just the space. So I'm sure you could do more. I just haven't had a need to.
Dr. Tanner or Dr. Dryden, have either of you had any experience with utilizing it in tendon sheaths?
Yeah, I've used it fairly routinely in tendon sheaths. I have not put more than 2 in one, but really haven't had a reason to. I mean, you look at some of those things, they're big. I mean, you get 10 mLs of fluid out of one. If you could put some more in if you needed, but that's been the scope of it.
I'm sorry, go ahead, Vern. I'm sorry.
I haven't used it in any tendon sheets, but I can guarantee you the next one I get, I'm going to try it.
Excellent. Question from Dr. Mosier. When you inject hawks, do you inject the DIT and the TMT?
I do.
Yes, I do. Unless it just can't get in there.
Yeah.
All right. This is a question I think will be an interesting one. In regards to, obviously many of you are doing re-injections with Arthramid, and based on some pushback, from clients, and how do you handle some of the pushback when it comes to terms of pricing, or how do you talk through that with your clients on the benefits of Arthramid and utilizing it and redosing and that kind of thing from a longevity perspective?
Well, I think in most cases, it'll sell itself if you can get the first dose in. But they also have to look at the longevity they're getting. For example, the one case that I presented of mine in that stifle, you would not have held that stifle with conventional joint injections for any length of time. So I think that the selling point is one, if you can ever get the first dose in, I think they'll be impressed with it. But the second is, I just try to explain to them the longevity or the longer period of time between injections, the economics actually take care of themselves.
Yeah, I agree. Yeah, just the length, the price kind of evens out lots of times. If you're getting 4 months versus 8, or sometimes I get 12, 13 months out of a lot of these horses in between doses if they don't have any real severe pathology. Instead of injecting them every 6 months. So.
And it's healthier for the joint. So
yeah, it's better for the joint for sure. Yeah, I think that some of the CSU study is going to elucidate even more of that as well. So.
I would say the same. I think once they see the effects and how well it works, it all evens out. I don't think that the cost up front. I think that is gone by the wayside by the time they realize that they're a year in and they haven't had to treat their hocks again. So I think the severely affected arthritic changes in joints, you're going to have to dose them more frequently, but in routine settings, I think that getting a year or more out of one treatment is that sells itself for sure.
Yeah. I would also just, again, reference that Stuart Valantis, his practice study where you're talking about length of time frame of having a horse stay sound. In that case, those 700 horses, it was 243 days as an average. So that's a significant number. And those horses are being raised hard. I mean, they're 2, 3, 4-year-old race horses. So yeah, I think it speaks to the length of time you have that interval of maintaining soundness in those horses with Arthramid. So again, I think the cost analysis works in the client's favor at that point.
All right, the last question that we have is, has anyone possibly used it or tried it in GSLD or superficial digital flexor tendon laxity for injury?
I have not.
I have not.
Nope.
Yeah.
Well, that leaves a great pending point for maybe one of you guys here to give us some further discussion for a webinar in the future. But we thank you so much, Dr. Tanner, Dr. Whitaker, and Dr. Dryden, for your expertise tonight on a great practical application on how these practitioners can apply this moving forward. And your time putting these cases together is very thorough and a great discussion. And Dr. Conway and Dr. Green for your contributions as well, and for all of you taking precious time out of your night to listen in. We're really grateful for that. You will receive your CE certificate at the end of day tomorrow, as well as a copy of this recording, so you can go back and rewatch any of the portions that you would like to just take a little bit more time with. And then if you would like to tune into our counterparts, our English Sport Horse, please come back on September 11th. It will also be at 8 p.m. on Thursday. And we would love to have this similar discussion, just looking at the other side of the business. So thank you all, and we really appreciate it, and have a great rest of your evening.
Thank you.
Thank
Thank
you.
y'all.
Thanks.